Most of us here, or almost everyone, has taken NSAIDs at some point or prescribed them. There's one of the most widely prescribed and recommended medications for pain. Everything from osteoarthritis. I personally use it a lot for migraines in my patients, and most of them are available over the counter. They offer moderate pain relief. And some of the things that we forget are the potential side effects, or maybe we overlook them sometimes when we're prescribing or taking these medications because they're so widely used. Just to go over some of the pathophysiology, they're COX-1, COX-2 inhibitors. Most of them are non-selective. We have some selective COX-2 inhibitors like celecoxib. And then the COX-1 inhibition mostly affects GI mucosa and the kidneys, whereas COX-2 inhibition affects and causes most of these cardiovascular risks like stroke and MI. So COX-2 inhibition is associated with reduced PGI2 production by vascular endothelium, and it prevents inhibition of potentially prothrombotic platelet thrombexane A2. So this can have sort of a two-hit, predisposing you to endothelial injury as well as creating a mildly prothrombotic state. And so that can increase your risk of MIs and stroke. We talked about these non-selective NSAIDs, whole list of them, and then in terms of the selective COX-2 inhibitors, most of them are associated with increased risk of MI and stroke. So in terms of cardiovascular risk, as far as MI is concerned, it's a dose-dependent risk. The greatest risk is in the first month of use. The risk is low. The absolute risk is about 0.5 to 1% per year. And the COX-2 inhibitors, most of the risk is within the first 30 days of use, or with use greater than 30 days, whereas most of the other NSAIDs is for use greater than a week. In terms of all cardiovascular death, there's a slight increase in cardiovascular mortality. Some of the risk factors that increase cardiovascular risk or cardiovascular death are advanced age, male sex, polyarticular disease, and then comorbidities like renal disease, diabetes, cancer. And then premorbid walking disability is also an independent risk factor. Interestingly, some of the disease-modifying agents for rheumatoid arthritis have shown some protective effects. So I found that interesting in my reading. In patients who have no cardiovascular risk factors, there's a low baseline risk in this subset of patients with NSAID use. There was a CNT collaboration that did a meta-analysis. They looked at over 600 trials, more than 300,000 patients. Most of them had no cardiovascular risks. And they looked at major events like MI, strokes, deaths. And there was an increased risk with both diclofenac as well as celecoxib. No significant increase in the risk with ibuprofen, and then no increase with naproxen at the doses shown. And then patients who had a baseline risk of 0.5% per year, again, diclofenac, ibuprofen, celecoxib showed slightly increased risk. Again, for short-term use, this shouldn't influence our use of these medications, especially in patients with no other risk factors. Moving on to patients with known cardiovascular risk factors, most of these patients are already on antithrombotic medications, so we generally avoid long-term NSAID use. But again, just to go over, you'd want to avoid these in patients with recent MI, angina, perioperative periods for CABG. And the risk is the greatest in the first few weeks of use, but improves with discontinuation. The Precision trial looked at patients with these pre-existing cardiovascular disease, and again, the naproxen was linked with about 2.5% increase in events in these patients, celecoxib with about 2.3%, and ibuprofen with 2.7% increased risk. With specific diseases, NSAIDs, both selective and non-selective, can worsen the control of hypertension, and the recommendation is to use the lowest dose possible and taper the NSAID rather than adding an additional antihypertensive agent. There's also a moderate or modest increase in the risk of AFib with chronic use of NSAIDs. And with CHF, there's a small increase in the risk of new CHF in patients with prior congestive heart failure. There's an increased number of inpatient admissions. And again, it was increased with diclofenac compared to naproxen. So depending on what your patient's comorbidities are, you might try to pick a specific NSAID. In terms of stroke, there's a small but significant risk of hemorrhagic stroke, both with diclofenac and meloxicam. There isn't great data on the others, but I think probably you could generalize this to some of the other NSAIDs as well. So in conclusion, some of the recommendations or considerations that we should keep in mind while prescribing or using NSAIDs. We should be aware that there's an increased risk of adverse cardiovascular events. Prescribe at the lowest dose for the shortest possible duration. And then patients with known cardiovascular disease or GI bleeding risk, you might consider the COX-2 inhibitors, but again, with the cardiovascular disease, the COX-2 inhibition does lead to increased risk of additional events. So that's it.